All right, Aaron Werner here, and excited to have Dr. Kyle Klute with us to talk about how to read a scientific paper and what goes into that. Certainly a big topic of discussion the last couple years, more so than I can ever remember. I know as doctors and going through school, we've talked about them a lot, but I think the layperson now has heard of studies and is more aware of studies and as have all of our news medias. But Kyle, before we get into that, tell us a little bit about yourself and the good life.
Thanks, Aaron. Yeah, I appreciate you having me on this. It's fun to talk about these things. I know it can be a little bit heavy of a topic once in a while, but it is super important. But yes, Good Life Eye Care is the practice that I started in Omaha, Nebraska. We have two locations, and one in Omaha and another one in a small town about 40 minutes away across the border in Iowa. So lots of fun that we're having here. Good Life is the old Nebraska state motto. That like when you're driving in Nebraska, the sign would say Nebraska ... the good life. And I think for me, like what we try to exude in our practice, that basically means just small town hospitality, like just knowing your patients really well, being really approachable, transparent, and hospitable. So we try to exude that. That's kind of our culture here is talking about the good life. So it's kind of fun, kind of a fun name
Awesome.
to use.
I like it. So diving into how to read a study, because they're super important, and as scientists, they guide what we do, or they should. Yes. And the evidence should guide our decision making. And you like to talk about how we don't make decisions for patients. We are their coach or their guide, helping them through eye care and healthcare and whatnot. And we want to make sure that I think we all say we want to follow the evidence, but reading the studies and knowing what the studies say help us make sure that we're following the evidence when we're recommending to treatments to patients. And then as consumers of healthcare, because not everybody listening to this is doctors, and even as doctors, we consume healthcare. We want to make sure that what we're being recommended to really is something that we subscribe with and follows our philosophy as parents and consumers of healthcare and patients ourselves. Anything to add there?
Yeah, absolutely. So one of the reasons why I became so interested in this, I guess the main thing that I am interested in is just that question of how do we make a really good decision for our patients? And I think a lot of times when we think about our patients and where they're at, the type of patients that we see, a lot of them, or like half of them maybe, are patients where you can just explain what you're thinking, and they will just look back at you and just say, "You're the doctor. You tell me what to do," right? Which I have actually in my Iowa practice, smaller town Iowa practice, I have way more patients that will say that to me, where they'll just look back and I'll kind of go through this elaborate explanation. They'll just look at me and just say, "I don't know. You tell me." And then in my more West Omaha practice, more suburban, the mindset that I have is more of I'm helping the patient make the best decision for themselves. So I'm more serving, I think of myself more as a consultant or a coach, where I'm presenting the information, the risks and benefits of the treatments, and then I'm helping them make the best decision about their eyes to help them be most consistent with their priorities and their preferences. And one of the things that you look back at you kind of mentioned at the start, last 2 to 3 years, we've been kind of inundated unfortunately, in a lack of reading the sources, I would say. We've been inundated with a lot of press coverage and a lot of really, like we talk about misinformation and whether you're, Facebook, Twitter, whatever, social media, news organizations promoting studies. And really when you take that information just flat out or straight from that source or from that news organization, it's really easy to be misled if you're not going in and you're reading the information for yourself. You're not going to the original source, going to the scientific paper, and then having a framework for how you're going to assess that information too. It's amazing how in the last 2 to 3 years, we basically have, we're unfortunately in our country right now, we're very tribal. We tend to be pretty angry at each other, whether you're on the left or the right. And unfortunately, we through COVID have essentially made specific treatments be Republican versus Democrat. The vaccines and the masks tend to be more Democratic treatments, and like ivermectin and hydroxychloroquine tend to be more Republican treatments. And that's just so silly, the way that has happened. But how we break through, I think, and how we can, as optometrists, do a much better job with our patients to kind of break through that is let's just have a framework for going to the original research articles and reading those, ignoring how maybe an expert that we like, or ignoring how maybe a magazine article or a news organization reported the information, kind of putting that to the side and actually reading the paper ourselves. I think is unbelievably important right now.
Yeah, couldn't agree more. Just forward. Getting past the sensationalism, let's get into the evidence and what we're really talking about. Because I think some of the studies, and certainly the one we're going to reference today, is really, really exciting. And so when you know the outcomes and what the study is showing you, you can get something to get excited about and communicate with patients to really help them.
Yeah,
so
absolutely.
What study are we going to use today as we walk through this method of how to analyze and read a study?
Good question. So we are going to break down, study from 2019 is from the Optometry and Vision Sciences Journal, the Academy of Optometry Journal. And it is a 3-year randomized clinical trial of MiSight lenses for myopia control. The lead author is Paul Chamberlain. Like I said, 2019 article. So it's a really pertinent article. It's if you're in primary eye care, if you're seeing a lot of kids, that should be probably the overwhelming majority of optometrists listening to this, that this is applicable to. So this is, regardless of what your vendor has said or your rep has said, or regardless of what you've seen in the, in the trade journals, I would more, not to insult them, but I would more like to call them trade magazines, not necessarily journals. But regardless of what we read there, here's the study. Let's just look at it and extract the information that we need to help our patients make the best decisions. So when I do that, so I've got the paper in front of me right now. You can kind of read through the abstract, and that's good. That's super helpful to kind of get an overall idea. But at the end of the day, what I'm trying to do is I'm trying to break it down in order to, like I said, help my patient make the best decision. And I think one of the reasons why we, and myself included, we tend to get intimidated by reading a trial or a journal article is because we get caught up in the stats, or we get caught up in the statistical issues with the paper. We don't really want to read about p-values and hazard ratios, and those just trip us up. So we just kind of throw it all out. I can't understand that. I'm just not going to read it. I'm going to read somebody else's interpretation of it. I like to we won't get into that today. It is helpful to kind of understand those a little bit, enough to get by. But you don't need to understand those things to really understand if a paper is applicable or helpful, or if something works or not. And I like to break it down in basically four different steps, 4 different questions that you're asking when you're looking at the paper. So I'll just go through those 4 right now. The first one is, what type of paper am I reading? Okay. Number 2 is make like comparisons. So, we'll get into the details of that, but what are they actually comparing? Number 3 is understand the chances that are involved in the treatments. And 4 is there consistency with this information or this data and my own experience, as well as the data, other data out there on similar treatments. So it's those 4, if you just kind of think through that grid of 4 questions, it's going to get you 80, 90% of the way to really understanding if this is a good paper or not. So let's dive in. So like I said, a 3-year randomized clinical trial of MiSight lenses for myopia control. We'll put a link in the show notes at the end here. But so if I'm looking at this, I'm going straight for to understand. I'm going to go straight to understanding what type of paper is this really. So the reason that's important is because we all have probably seen. We remember from that, 20 minutes or maybe longer hour course in optometry school, or maybe we've read it online, of the pyramid of evidence, and where the bottom of the evidence, the higher you go in the pyramid, the better the evidence is, or the higher the quality of the evidence is. So if you can kind of visualize that pyramid, the bottom is going to be more like the case reports, individual case reports. And then moving up is going to be your more like, you can do like case controlled, or you can do a bunch of case reports on a similar disease put together. On top of that is going to be observational data. So it's like these huge, like, several thousand or tens of thousands of people in a cohort that they essentially just draw correlations with. They draw associations between certain things within the cohort. And then on top of that, even better than that, is the randomized controlled trial, and that's kind of our gold standard. But even on top of that, then, is going to be a review or the meta-analysis where they take all the RCTs, they put them together, they apply specific statistics to them, and then they extract out how good that intervention really is based upon a bunch of different RCTs. So even better, we want more information. It'd be so great if we had all these RCTs that we could put together, right, and actually create a gigantic RCT, and that's essentially what a meta-analysis is. So that's going to be even better. So for us here, when we look at this paper, we're looking at a randomized controlled trial, or randomized clinical trial of MiSight lenses. That's in the title. So we know that the higher up you go in that pyramid, where this is the gold standard type of a trial or of a paper, the higher up you go, the less bias there's going to be in this information, and the more generalizable we can take this information and apply it to our patients. So that leads us into that first C, which is, like I said, make like comparisons. So we all tend to avoid this all the time. I mean, I do it all the time too. Sometimes we want to skip we can read the introduction, and then we'll read the results and maybe the discussion. We always ignore the methods or the study design, but don't skip the study design. For example, let's see here. I think it's the third page of the study here. I'm looking at table 1 is the inclusion and exclusion criteria. You have to know, is this group of patients, is this group of test, subjects actually patients that I'm going to see, or actually patients that I'm going to work with someday, right? Mm-hmm. If they're not, then the paper isn't very valid for you. So like this paper here, between all patients are between 8 and 12 years of age. They were all corrected to 20/25 or better in each eye. Their spherical equivalent refraction was between 0.75 and -4, or minus 0.75 and -4. Their astigmatism was less than or greater than or less than or equal to minus 0.75, and then their NISO was less than 1. So when I look at that, I see, okay, this is a group of patients that I see all day, every day. I see a lot of kids in my practice. So yes, I'm going to see a bunch of 8 to 12-year-olds in between, like basically emmetropic and -4. So this study is for me. Very good. When this goes wrong is when we have, there's an example that I can share real briefly. There's a trial that is really prominent in our industry, or a lot of times we hear people speak about in the anterior sagre cornea. It's called the SCUT trial. It's the steroids for corneal ulcer trial. And it basically showed us that if somebody has a bacterial corneal ulcer, that it's okay, or probably best, to wait about 48 hours for us to start steroids on that patient. Or at least that's one of the applicable pearls that we can derive from that study. And I think that's really gone out. A lot of people, I remember learning that in optometry school. I remember reading about it. I've heard it, talked about and lectured on a lot in the past several years. But what we don't realize, if you go back to that study, the 500 patients that were included in that study, the overwhelming majority of them were farm workers that were the corneal ulcer was derived from a foreign body, and usually, I think the majority of them were vegetative matter, and only 8 out of the 500 were actually contact lens patients. So to me, I can't really take that data. Once I found that out, or once I realized that about that paper, it's like, well, that's not really applicable to me. Maybe it is for some rural practices, but I have mostly contact lens patients that are the ones that have the corneal ulcers that I got to deal with. So I'm not really going to use that to determine when I need to treat with a steroid. So it's super helpful to understand that.
That makes sense.
Next one then that we're looking at is understand your chances. And this is where we get a little bit into the weeds. So I'll try to be as brief and helpful as possible here. But this is where you got to look at the data, the actual data in the study. And you need to look at, and a lot of times the study itself won't give you these exact numbers. You kind of have to pull out your pen and paper and your calculator and calculate it yourself. But what I like to do is I like to understand the chances of a patient having a significant outcome. Because at the end of the day, that's kind of what we're doing, right? That's why we're making a decision for a patient. So the number I always want to go to, or the value that I'm after, is what's called the number needed to treat. So the number needed to treat is essentially, if I were to treat X amount of patients, or what is the amount of patients that I need to treat for one patient to have some sort of an outcome? Or, for example, like the ocular hypertension treatment trial, the number needed to treat for that particular study is I need to treat 16 patients for one patient to have their risk of converting to glaucoma reduced. So the same thing goes for any other study, because you can actually use that number. If you calculate that number, you can actually apply that number to educating patients better, and you can actually correlate or compare that number to other treatments that we have in our profession and other treatments that other practitioners are using, like prescribing statins or metformin or anything like that.
Nice. So you want to really help by knowing that number needed to treat. What you're looking for is how to guide a patient in making the decision on what treatment option they should go for.
Yes, absolutely. So one way we can look at that, let's just look at the study here, the MiSight study. When I'm looking at, there's figure 3, and one of the most important paragraphs is, I think, in page 4 or 5. I don't have it exactly in front of me, but basically it says that if you look at the numbers, it says in the treatment group, so in the MiSight trial, they essentially compared 8 to 12-year-olds, where they put half of the patients on the MiSight lens, and then the other half of patients they put on a placebo. So I think they used just a one-day ProClear lens was the control, or was the placebo, and then they compared them over 3 years to see which ones progressed and how much they progressed. And one of the most helpful pieces of information to me is, like, in the treatment group, after 36 months, 18% of those patients progressed by 1 diopter. Whereas in the control group, the ProClear 1 day, the non-MiSight lens group, 62% of those patients progressed by 1 diopter. So well over half of patients, and that's what I could tell a patient there. It's like, that's why I like to look at that information that way, is I could say, you know what, I could present it as, say, 100 patients are given the lens and 100 patients are not given the lens. I could say about 18 of those patients, or flip it around, 82% or 82 patients did not progress by that 1 diopter. Whereas, 62% or 62 patients in the other lens that weren't treated by this lens progressed by 1 diopter. I think that's more helpful to us than just talking about, like, oftentimes papers will quote the relative risk reduction or the absolute risk reduction, which is a little bit better. But oftentimes when we see a paper quoted in some sort of magazine article or in the news, oftentimes the relative risk reduction is reported, and that tends to be like overemphasized and kind of magnified, and it's usually a little bit misleading. So I tend to try to steer clear of those numbers if I can. And then if I were to calculate the number needed to treat, essentially, I'm just taking those two numbers, which is the difference. I'm taking the absolute risk, which between that 18% and the 62%, and I'm basically doing 1 divided by that. Okay, and that's your number needed to treat. So in the case of the MiSight lens, the number needed to treat to prevent one patient from progressing one diopter of myopia is I just need to treat 2.3. So the number needed to treat is 1 and 2.3, which is an insanely low number.
Yeah.
So it's really, really good, and that's why it's super helpful to share with patients when it is a good number like that.
So nice. And to put that into perspective, what are some other treatments that we know the number needed to treat? Well, we can calculate it on anything, but what are some other common treatments that we see in healthcare and medicine, and their relative number needed to treat, just to put that 2.3 into perspective?
Yeah, great question. Like I said, for oats, it's about 1 in 16. For a statin, it's anywhere between 1 in 80 and 1 in 100. So, we have patients, it seems like any more these days, any patient over 40, 45 is on a statin. And they, you hear people joke about how they need to put statins in water and just have everybody treated. But the reality is the number needed to treat is actually 1 in 80 or 1 in 100. So if we're that heavy on the emphasis on that type of treatment and are that positive on it, look and see some of our treatments actually are so much better than that. And not just the MiSight lens, but when you start looking at this number at a lot of our treatments in our industry, we start to realize wow, we actually have a lot of great treatments and a lot of ways that we can really help our patients reduce the risk of poor outcomes and intervene and treat and manage conditions really well.
Yep. Absolutely. And the way I describe it to patients is, and it might be simple, but it works for me and it makes sense for me and seems to make sense for them, is that what are the chances that I'm going to buy a winning lottery ticket? And if I've got a 1 in 100 chance of buying the winning lottery ticket, well, if it's the Mega Millions and there's 100 million or $1 billion in there, I'm probably going to buy a ticket. But it certainly is much more exciting to buy a ticket when my odds are 1 in 2.3. And I'm going to buy a lot of those tickets because it just makes sense. The chances of a positive outcome happening are much higher. And it's worth the risk. In this case, for the lottery tickets, my risk is only, financially spending money. And that may be some of the risk of, or the negative side effects, if you will, of any treatment, spending money. I've got to wake up earlier in the morning to put contacts in. Maybe I've got to put them on my kid in the MiSight trial. For statins, there's certainly health side effects. And so what's as a patient, what's my risk tolerance in trying to get that good outcome? So that lower number needed to treat is like buying not guaranteed or getting a winning lottery ticket, but you're much more likely to get one. Pretty darn close. Yeah, yes. Absolutely.
Yep. Yeah. It's really just like when we talk about certainty and uncertainty, it's just reducing the uncertainty there of your outcome. And that's, when you kind of think of big picture, I think a lot of times one of the reasons, I think there's a lot of other reasons, but one of the reasons why I think sometimes we hesitate in offering specific treatments to our patients is because we may not actually believe that they work, or we don't have a really good understanding. It's not necessarily an understanding of how they work, but really we may not be sold that it's actually going to help or not. And when you put it into the terms of I guess I'll go back. At the end of the day, we don't know. There's really no way of knowing whether, and there's no way of being certain that the treatment or our intervention into something is actually going to help them or not. But when you look at the data yourself and calculate the numbers like that, it actually, it takes you kind of off the hook in terms of being I think sometimes we feel like we're salespeople. We're trying to push people into certain treatments or something like that. And you're just frankly giving them the objective information like, hey, this is what the study did. And this is the reason why we put the study together like this. And this is what the information shows. And then you can actually weigh in like, hey, and honestly, like this is 1 in 2 or 1 in 3, but there's treatments like maybe a treatment, are you on maybe not aspirin on a statin, but there's treatments that you're probably on that have a lot less likelihood of reducing the risk of a poor outcome than what this is. So I think it equips you just with more confidence in what you're prescribing. And then sometimes you're going to calculate these numbers and you're not going to be nearly as certain or confident in what we've been prescribing. I won't mention any specific treatments out there, but that's the value of looking at the research yourself so that you can know for your own patients and for your own, confidence of helping patients and prescribing the way that you'd like to guide patients.
Absolutely. Awesome. So we've got, so getting back to how we walk through the reading a clinical study, we look at what kind of study it is, so we know where to place it on that hierarchy. They all have value, but where do we put it? And then I'm going to recall your last 3 points, 2, 3, and 4, your 3 C's. So you're comparing, right? How did the patients in the study compare to my patients and my practice? And then understanding the chances. Right, and that's that understanding the number needed to treat, and what are the chances that this is going to work for the patient. And then what's your last one?
So the last C is consistency. So is this information or the results of this study consistent with what I've seen already in my practice, in my patient cohort? Which you got to be a little bit careful with that because you can be biased, but also, is this information or these results consistent with what other studies have said as well? So, like when I look at this MiSight data, and then I just compare it, is this consistent with treatments? Obviously, this is not the same treatment as atropine or the same treatment as orthokeratology lenses, or the same treatment as other, daily lenses that are similar to or have are within that same treatment realm, but when you do look at it at the end of the day, the numbers within this study are very similar to and are consistent with treatments across the board, kind of around that 40 to 55, 60% effectivity. So, if you get some information where it feels like this trial is showing that this intervention or this treatment is a game changer, then that's probably something you need to question and look and see, and maybe look elsewhere, or ask for more data, or even just like wait for another study to come out, wait for another analysis, or wait for somebody else to interpret that before you look into it. Or if it doesn't even fit, like one of the things that I think we won't get into the DREAM study, the omega-3 study that was done, but there's an inconsistency there. There's a number of factors that cause this, but there's a little bit of an inconsistency with the results of that trial with some of the results of other trials that have been done. And if there's inconsistency between the results of that trial with what other practitioners have kind of experienced in their practice on the value of omega-3s as well. So that doesn't say that what the study has found is wrong, but it may mean that there are some comparisons that are different. There may mean that like in the DREAM trial, that specific treatments should have been excluded or included with the cohort. There may be just other confounding variables within the study that we don't really know about. So it's just helpful to always have that in mind, like, okay, is this data similar to this data? And if it all does seem consistent, then we can probably take it and run with it.
So, perfect. And that really plays into the art and science of medicine. Right?
Amen.
Is everything, all the evidence pointing to one new thing, not to say that there isn't a game changer that comes along, because that certainly does happen, but it needs to be reaffirmed that it truly is a game changer. And then the art is how we work with patients. I'm jealous I don't have patients that just blatantly trust me. They like to question, and even more so after the last couple of years. But that's a good thing. Questioning's a good thing. We should be questioning, and because questioning doesn't mean denying. Questioning means just finding out more information and getting those consistencies of confirmations of consistencies, so that we can take better care of ourselves, our patients, and progress medicine and science along. So. Absolutely. Awesome. Well, Kyle, really, really appreciate you walking us through this. If you've got any more questions, go back and re-listen. I encourage you, if you are not doing this, looking at the study rather along with us as we go through, find that link and re-listen to this and go back and follow the discussion through that study. If you don't like math or your calculators, there are number needed to treat calculators that you can find online that where you put in the the control group percentages and experimental group percentages, and it'll generate that number needed to treat for you. But let us know your thoughts. Let us know what other discussions you'd like around this and understanding studies and clinical research. Because once you get past the p-values and all the stat stuff that I think some of us probably avoided in college, clinical research is exciting. It's pretty cool to see what they're studying, what they're looking at, and the new evidence that's coming out in medicine.